Welcome to my webinar. My name is Segal, and I am the Digital CAD/CAM Manager of Paltop Advanced Dental Solutions. My first exposure to CAD/CAM products came in the late 90s, when as a laboratory owner in Israel and consultant for Noble Biocare, I possessed a Noble Forte scanner for Procera. In 2005, I became a mentor for Noble Guide computer-guided software, and so began my fascination with computer-guided surgery and my role as a provider of planning services. In 2009, I moved over to Biomed 3i and Simplant. Using Simplant as a generic software for all implant systems gave me greater exposure in the field. In 2015, in conjunction with a local chain of CT centers, I began providing planning services using 3Shape Implant Studio. Today I am proud to be the Digital CAD/CAM Manager of Paltop Advanced Dental Solutions. Let's review some of the essential elements to gain the advantages of technology in implant dentistry. Surface scan with the intraoral scanner or optical scanner. Cone beam scan. Prosthetic design software. Surgical planning software. CNC machining. 3D printing. Computer-guided surgery systems, and a technological compliant implant system. The list is long. Now allow me to simplify this for you by pointing out that in modern digital dentistry today, the dental laboratory takes a major role in digital technologies, such as the prosthetic design software, surgical planning software, CNC machining, milling, 3D printing, and prosthetic components. This workflow will be both time efficient and cost saving. Your first appointment may include taking medical history, clinical images, CBCT, and an intraoral scan. Your next appointment will be on the day of surgery, where you will have all the necessary components ready in advance, such as the surgical guide, implants, abutments, temporary restoration, instruments, regenerative materials, and more. In today's lecture, I will focus on the prosthetic and surgical softwares, the guided surgery system, and the technological compliant implant system of Paltop. In my role as service provider, I often go out to assisted surgeries, offering technical support. I would like to give my special thanks to Dr. Gil Asafrana, Ben Yozari, Ilan Tirosh, and Andy Boanjo for their cooperation and the digital case studies I will show in the second part of today's presentation. Paltop offers a broad range of solutions for the complete digital workflow for the doctor and dental laboratory, including surgical and restorative digital applications. Paltop's digital treatment workflow enables doctors to perform simple, safe, and accurate pre-planned surgical and restorative procedures using cutting-edge technology. Before we take a closer view at guided surgery digital solutions and restorative digital solutions, it is important that we go back to the basics and understand the requirements for a digital platform. Digital libraries and CAD/CAM restorative components. We have two categories of digital libraries, restorative and surgical. Paltop's restorative components are integrated into 3Shape Dental System, Dental Wings, and ExoCAD. Paltop implant libraries for implant planning software are to be found in 3Shape Implant Studio, Blue Sky Bio, Exoplan, 360 Image, and coming soon, Anatomage. You may find our digital libraries on our Paltop homepage. Click on Digital Service and click on the icon for Digital Libraries. This will open all the libraries for Paltop restorative components. Please note that the libraries have been updated regularly. Ensure that you have the latest version. Another essential ingredient for a digital platform is custom milling solutions. To achieve this, Paltop has teamed up with Amann Girrbach, NT Trading, and Zirkonzahn custom milling solutions. Let's take a look at the NT Trading solutions. We have NT Trading preforms for custom abutments for both the narrow, standard, and wide platform internal hex connection and for the conical connection. We have NT Trading scan abutment, NT Trading preform, the digital analog for a 3D printed model, and the milling analog. Please note the original holder for NT Trading preform requires the milling analog. The new fixture holder functions without the need for a milling analog. The list of milling machines compatible with NT Trading are to be found on the Paltop internet site or on the NT Trading site. We have also teamed up with Amann Girrbach. We are now manufacturing in-house Amann Girrbach blanks for narrow platform, standard platform, wide platform, and the PCA conical platform. The Amann Girrbach milling blanks are now to be found in the Paltop catalog. Please remember that when using Amann Girrbach, you must download the library and ensure to use the Paltop scan bodies. Paltop prosthetic components now appear in the Zirkonzahn library, and they will be coming soon. So now let's talk about tie base abutments. The unique concave design of the tie base abutments enables the mucosal tissue to form a dense layer surrounding the transgingival connection. This results in reduced tissue transparency and reduced metal visibility of the abutment. This innovative design creates an optimal emergence profile. All Paltop's prosthetic components have an identical concave profile, allowing the replacement of components according to the treatment stage. Paltop goes the extra mile by ensuring that not only the implants but all the prosthetic components are delivered in sterile packaging. Now let's focus in one moment on the tie base round for the internal hex connection. The tie base comes in two lengths, 4 mm and 6 mm length, and comes in a selection of cuff heights, 0.5 mm, 2 mm, and 3 mm in height. And the tie base comes for engaging for single crowns and non-engage for multiple units. This is true also of the narrow platform tie base, the wide platform, and the conical connection. Paltop introduced the tie base anterior for improved aesthetics in the anterior region. The tie base anterior is available for both the narrow platform, standard platform, and conical platform in different cuff heights. Here we'll review the design of an anterior crown using Exocad. Following the job definition, the model and the scan body are scanned with an optical scanner. The scan body is matched in the software, and a 2 mm height round anterior tie base is chosen. Now the crown design can be completed. The palatal aspect of the crown design can follow the correct anatomy due to the improved geometry of the tie base on the palatal aspect. Once the crown design is complete, the STL manufacturing file may be generated. Another exciting tool for CAD/CAM prosthetics is the ACS abutment, Angulation Corrective System. The ACS abutments are designed for the manufacturing of CAD/CAM screw-retained restorations, where angulation of the screw access hole is required for improved aesthetics and function. The ACS system permits angulation of the screw access hole up to 20 degrees. This is achieved with the aid of a special designed abutment screw and screwdriver. The ACS abutment comes for both narrow platform and standard platform in 2 cuff heights, engage and non-engage, and for the conical platform in 2 cuff heights, and comes with its own manual hex screwdriver and hex driver for ratchet. The ACS abutment offers the dental technician control over the desired position of the screw access hole. This is beneficial, particularly in the anterior segment, to ensure the screw access hole is in the cingulum area without compromising the buccal aspect of the soft tissue, and with the use of an angulated abutment. Please note that in order to achieve the desired result of angulating the screw access channel from the buccal to the palatal aspect, it is essential to ensure the correct orientation of both the implant and the scan body. The flat of the implant must point to the buccal aspect. The point of the scan body must point to the buccal aspect. So let's briefly review the workflow with the ACS abutment in 3-shape dental system. Following job definition, an ACS component is chosen in accordance with the platform and the cuff height. Go through the occlusal alignment stage. So now we can see the ACS abutment with the window on the palatal aspect. Continue with the design of the emergence profile. Continue with the design of the screw-retained crown. Here we can see the screw access channel prior to correction. This case was originally planned in 3-shape implant studio, and you can see on the right in the image the long axis of the implant exiting at the incisal edge of the crown. Following the angulation of the screw access channel to approximately 17 degrees, we can see that the axis of the channel is in the cingulum area of the crown. Now let's review the Paltop scan bodies. The scan bodies are available for the multi-unit abutment, single unit abutment, and for all the 4 platforms of the Paltop implant system. The titanium part of the scan bodies are color-coded, and the peak component of the scan bodies are engraved with an identification mark for each platform. The screw of the Paltop scan bodies has been modified and is now fully retractable. This will enable cleaning of the screw access channel and sterilization of the scan body and the screw separately post-use in the oral cavity, preventing cross-contamination. The Paltop DIM analogs are also available for the multi-unit, single unit, and for all the implant platforms. The Paltop DIM analogs come in 2 components. The upper section with the platform seats inside the housing for the DIM analog. The lower section, the retaining screw, anchors the DIM analog into the 3D printed model. So now let's review some clinical digital cases. This first case, courtesy of Dr. Gila Safrana, is for a full arch screw retain bridge on multi-unit abutments. When using a digital workflow, it is possible to dramatically reduce the chair time required and the number of appointments. In this case, the existing temporary bridge could function as a template for the final bridge design. Using intraoral scanning, it was possible to record abutment position, soft tissue, pre-preparation scan, in this case the scan of the temporary bridge, the opposing arch, and the bite registration. Here we see the result of the intraoral scan using the 3-shape Trios scanner and the multi-unit scan bodies. With the full digital scanning complete, the dental laboratory is able to design the final bridge based on the existing confirmed bite registration and the pre-preparation scan, in this case the temporary restoration, thus combining a number of analog stages into one simple digital process. The final restoration was manufactured using a 3D milling process from a hybrid graphite composite. Using a digital workflow ensures that the virtual setup and manufacturing files can be safely stored for the future use. Following the final seating of the screw-retained bridge, the screw access holes are sealed and the restoration is complete. The use of a hybrid composite with high tensile strength offered an aesthetic, resilient, and cost-effective result. Taking advantage of such a digital workflow is beneficial to the clinician, dental technician, and patient. Before we move on to review some clinical guided surgery cases, I would like to point out some of the special features of the Paltop guided surgery kit. The surgical kit includes a dedicated contra-angle and the unique digital guidance system, or DGS as it is known for short. The DGS guides the contra-angle through the surgical guide sleeve to accurately position the drills in accordance with the virtual planning. The window on the DGS enables continuous direct irrigation on the drill throughout the drilling procedure. Many surgical guided systems require drill keys for drill guidance. This will often necessitate an extra pair of hands to stabilize the guide and the drill key. Using the DGS simplifies the procedure. The guide sleeves in the DGS come in 2 diameters for ideal implant spacing and distribution. Angled entry is possible into the surgical guide. This is particularly significant in the posterior segment where there is less inter-arch space. Implant placement can be achieved with orientation, direction, and depth control. We have an intuitive guide sleeve design with a hexagonal shape and a groove indicating the exact position of the flat of the buckle of the hex. There are 3 drill lengths for maximum flexibility. The drills are color-coded, 20 mm length with brown, 25 mm purple, and 30 mm length silver color coding. The Paltop fully guided surgical kit covers implants of lengths from 6 to 16 mm and implant diameters from 3 to 5 mm. Finally, the fully guided kit facilitates a simple sequential drilling protocol. The first case, courtesy of Dr. Ben-Yozari, is a partially edentulous case in the maxilla. Implant planning is required for teeth 15, 13, 24, and 25. A 2-supported surgical guide will be manufactured. Teeth 15, 14, 13, 24, 25 and 26 will be extracted, and there will be planning for a full arch immediate cement retained bridge. In the anterior segment of this case, there is an existing porcelain bridge. This will provide support for the surgical guide during the surgical phase. On completion of placement of the implants, the porcelain bridge will be removed, exposing the prepared teeth. The next step is to synchronize the upper surface scan of the model to the DICOM. 3Shape Implant Studio offers a color scale to assist with evaluation and verification of the alignment. Green coloration indicates zero deviation. On confirmation of the alignment, it is then possible to move on to the planning stage. Tilted implants were planned in accordance with the prescription instructions. The prosthetic options were evaluated with the help of generic abutments available in the software. In the cross-sectional view of implant 15, we are able to see the geometry of the implant, the surrounding safety zone, the bone anatomy, and the soft tissue outline with the aid of the surface scan of the model, and also the abutment and abutment angle. Implant 13 was planned in an extraction site. The contact area of the surface of the implant in the surrounding bone was evaluated. This was done to see if primary stability could be achieved. Implant 25 is tilted distally. This will reduce the size of the distal cantilever of tooth 26 in the final restoration. The apical portion of the implant threads engage the cortical bone of the sinus mesial wall. Implant 24 is planned in the narrow corridor between the root anatomy of tooth 23 and the distal implant. Whilst the safety zone of implant 24 is reduced, to achieve this, careful attention is given to ensure the apex of implant 24 does not collide with the adjacent implant 25. Using 3D software, it is possible to lock the implant view onto the long axis of the implant and to revolve around the axis 360 degrees. This advanced feature of the software offers a unique view of the surrounding anatomy. Prosthetic-driven implant planning with the aid of the generic abutments enables abutment selection, both cuff height and angulation. In this case, for a cement-retained prosthesis, the distal abutment is set to 25 degrees and the mesial abutment is set to 15 degrees. Stock angulated abutments will be chosen from the Paltop system. Following final approval of the implant planning by the practitioner, it is then possible to design a working model with housings for the digital analogues. The DIM analogues will represent the implant platform, depth, direction, and orientation. The manufacturing STL files of the working model and antagonist are sent to the dental laboratory. The model STL files are 3D printed, the DIM analogues inserted, and the stock abutments seated to the analogues. Some minor adjustment to the abutments is carried out to ensure that they are parallel, and the finish line of the abutment is defined. The prepared abutments are scanned with an optical scanner, and copings are designed and manufactured in PMMA. The copings not only cover the screw access channel, but also have an intimate friction fit with the abutment finish line. The model is scanned for a second time, and a one-piece temporary cement retained bridge is designed. The distal segments of this bridge will seat on the abutment copings. The anterior segment will seat on the prepared teeth. Following osseointegration of the implants, a final bridge will be delivered in 3 segments. Using digital technology, it was possible to prepare models, abutments, and temporary restoration prior to surgery. The external surface of the temporary bridge offers an ideal aesthetic anatomical design. The fitting surface of the bridge is hollow to facilitate a simple reline of the bridge after initial seating. The surgical guide and the temporary bridge and prosthetic components have been delivered. The first step is extraction of the distal teeth, as set out in the prescription. This is done atraumatically. Next, the surgical guide may be seated. The surgical guide will not only seat on the anterior bridge, but also on the palatal area and on the tuberosities. The inspection window on the surgical guide enables validation of the correct seating of the guide, checking for the intimate fit between the surgical guide and the adjacent teeth. Once the seating of the guide is confirmed, it is then possible to continue with the drilling protocol. The drilling protocol will involve a sequential order of the guided drills in accordance with the correct drill length and diameter. The first drill is 2 by 2.4 mm in diameter as a stepped drill. The second drill is 3.25 mm in diameter, and the final drill is 3.75 mm in diameter. The implant diameter in this case was 3.75 mm. In soft bone, an under drilling protocol may be necessary in order to ensure primary stability. The implant is delivered through the surgical guide with the guided implant key. The offset for this implant, as defined by the drilling protocol, is set at 12, and so the implant is inserted through the guide sleeve with the implant key until it reaches the depth of offset 12, and the vertical groove of the implant key is in line with the groove of the guide sleeve. We can be sure that we have the correct orientation of the implant. By following the drilling protocol, the implants can be placed with the correct depth, direction, and orientation. Now the anterior bridge is removed. Following the removal of the anterior bridge, tooth 12 is extracted. The abutments are seated onto the implants in accordance with their position on the working model. Now the PMMA copings can be seated on top of the abutments. They seat with the friction fit. The copings are protecting the screw channel and have an intimate fit with the margin on the abutments. The bridge could now be seated over the copings in the anterior teeth. There were no premature contacts, no interference over the PMMA copings or over the anterior prepared teeth. The occlusion was accurate. All that remained was a simple and short procedure to reline the bridge, complete the final shaping and polish. The use of computer-guided planning enabled the preparation of all the components prior to surgery, resulting in a swift and accurate surgical procedure and simplifying the completion of the temporary bridge. The considerable saving in chairside time far outweighed the preparation of the planning stage. Ultimately, the patient benefited from a short treatment protocol. The next case, courtesy of Dr. Ilan Tirosh, is a partially edentulous case in the mandible. Implant planning has been requested for teeth 47, 46, 44, 42, 32, 34, 36, and 37. A two-supported surgical guide will be manufactured. The case is planned for full clearance, and Dr. Tirosh would like to place a screw-retained immediate bridge. So now that we have reviewed the instructions, we can see that there is a contradiction. The case is planned for full clearance, and yet a two-supported surgical guide is requested. Therefore, we must understand during the planning stage how we can achieve this. Here we see the preoperative clinical images. Computer planning of the implants is completed in compliance with the prescription form. Now that the computer-guided implant planning is complete, it becomes clear that the surgical guide can seat on tooth 48, 43, 33, and the retromolar pad on the left side of the jaw. So we've been able to meet the challenge and indeed offer a two-supported guide even though the case is designated for full clearance. As we did in the previous case, A working model is designed and prepared, together with an opposing arch and a simple 3D printed articulator. The surgical report will define the implant type, dimensions, and tooth position. Here we see the final manufacturing files for the working model. You recall that the support of the surgical guide will be on 3 remaining standing teeth and on the retromolar pad. The 3D printed model was delivered. The canines were extracted from the model. Multi-units were connected to the DIM analogues, and temporary titanium sleeves were screwed onto the multi-units. Dr. Tirosh was now able to scan the multi-unit abutment sleeves, together with the working model in the opposing arch, and to design a hybrid screw-retained bridge. This was done using ExoCAD. The manufacture of the immediate temporary bridge was done through milling, using an Amann-Gerbach Ceramill motion milling machine. You can see on the fitting surface of the bridge the cavities housing the temporary titanium sleeves. And when you review the occlusal aspect of the bridge, you can see how the implant planning guaranteed the correct placement of the screw access channel for all the implants. The surgical guide is complete, and as specified before, it will have 4 points of support. The surgical guide was very stable during use. The anterior implants were planned taking into consideration that there would be some bone reduction in the anterior segment. The use of the surgical instruments through the surgical guide was made simple by having clear visibility. Even the placement of the implant could be viewed during the process. On completion of the placement of the implants, the straight multi-units were connected. The ideal cuff heights of the multi-unit abutments were chosen during the computer-guided planning stage. The bone harvested from the reduction of the anterior portion of the ridge could be used to fill the socket areas. The completion of the suturing of the soft tissues and the luting of the temporary bridge was a quick and efficient process. Every computer-guided case has its challenge. In this case, a tissue-supported surgical guide would not have been stable. The manufacture of a bone-supported guide would have been extremely difficult, especially taking into consideration the bone reduction in the anterior segment. Computer-guided prosthetic-driven implant planning resulted in ideal distribution of parallel implants for a screw-retained immediate prosthesis at the level of multi-unit abutments. This was achieved in one sitting with the aid of a stable tooth-supported surgical guide. Paltop offers a simple guided solution with the Pilot Surgical Guide Kit. The kit includes a first pilot drill and the initial 2 mm diameter drill offering location, angle, and drill depth. The drills come in 20, 25, and 30 mm lengths and are color-coded: brown for 20, purple for 25, and silver for 30. Combining the pilot kit together with a unique step drill system and drill stops enables precise rapid implant positioning. When is a pilot surgical guide recommended? When there is a need for an accurate entry point and inclination of the drill site. For predictable and safe drill depth control with simple drilling protocol. For prosthetic-driven distribution of the implants. It is recommended for cases with type D1, D2 bone. High-density bone enables the clinician to follow the initial pilot osteotomy without deviation. Use a pilot guide to avoid anatomical structures. And for cases where the clinician prefers to review the initial osteotomy and follow through with freehand technique. Here we see the prosthetic-driven implant planning. The correct pilot guide sleeve is selected following the planning. The sleeves are color-coded, indicating the chosen drill length at the planning stage. Following approval of the implant planning, the 3D printed surgical guide and model is manufactured. In this case, courtesy of Dr. Andy Boanjo, X-ray verification of the parallel pins clearly shows the drill depth and the proximity to the inferior mandibular nerve achieved with the pilot surgical guide. The drilling protocol was completed freehand using the drill stops, and the implants were then inserted. To summarize, let's review some of the benefits of computer-guided surgery. It offers predictable surgical and prosthetic-driven implant planning, functions as a comprehensive 3D communication tool for the medical team and the patient, offers increased patient acceptance of treatment protocols, is more cost-effective, immediate temporary solutions are possible when applicable, allows for minimally invasive techniques, there is a reduction of post-operative pain and swelling, eliminates unpleasant surprises during the procedure. Therefore, it reduces clinical and patient stress levels and reduces the amount of chair time. Finally, with the growing trend of inexpensive desktop 3D printing, the manufacture of surgical guides and temporary restorations is more affordable, immediate, and in-house manufacturing is now possible. Thank you for listening. If you would like to contact me regarding Paltop prosthetic CAD/CAM components, digital libraries, or the Paltop guided surgery kit, please connect via email or LinkedIn.
I see that we have a few questions here, so I'd like to go over the questions. I hope you found that webinar informative and gave you an introduction at least into Paltop digital products. So the first question that I have here is, does the digital planner also plan the restoration? Great question. So if you recall the beginning of this webinar, we showed the workflow, the kind of ideal workflow that should be for you, for your clinic, for your dental laboratory. The Paltop system prides itself in being an open system, and we would like to enable our customers, whether they are clinicians in the dental clinic or dental technicians in the laboratory or special guided centers, we would like everybody to have the opportunity to take part in planning cases for the Paltop system. So the answer to this question is really, it depends very much on your desired workflow. If you feel comfortable with sending your cases to your dental laboratory and have them plan the guided case for you, go ahead and do that. That's great. If you would like to plan the cases yourself, the implant planning, and then have your dental laboratory plan the prosthetics, that can also be achieved. So what works for you is really the answer to that question. So let's scroll down now and take a look at some of the other questions. Okay. Can I use a prefabricated abutment, or do you need an individual one in digital cases? Again, a great question. So really, what I aim to do when planning a case, a computer-guided planning case, is to enable the clinician to use a stock abutment. This simplifies the procedure, makes the procedure less expensive, and I think it helps the workflow go quickly. So definitely when you're planning, keep in mind what has been requested, whether it's screw retained or cement retained. Ensure that you provide the correct angulation to offer solutions to either system. For example, if it's cement retained, so you may have a straight abutment, a 15-degree abutment or a 25. If it's screw retained, then perhaps a straight multi-unit, a 17-degree multi-unit, or a 30-degree multi-unit, and take advantage of the software to analyze this and find the best possible answer. Wherever possible, you should be trying to use the stock abutments, at least for the temporary prosthesis. If you afterwards produce your final prosthesis and you wish to have a more aesthetic solution, you may choose to transfer to zirconia abutments for this. Okay, so let's just scroll down here, just 1 minute, please. Okay. So can I use the DGS with other implants or different implant kits? So the DGS tool is unique to the Paltop system. It functions with the Paltop implant system, and we have recently introduced the DGS tool also into the Keystone system for Keystone Genesis implants and the Keystone Prima implants. The system functions with a specific drill length. Therefore, it should be used as a system specifically for either Paltop Genesis or Prima, but rather an exciting addition to the Paltop surgical guided system is the fact that, if you recall, we have 3 different drill lengths, and the middle drill length was 25 millimeters, the 3 lengths are 20, 25, and 30. And we have recently integrated our system together with the Versa drills, which are also 25 millimeters in length. So should you decide to use the DGS tool and the Versa drill to achieve bone density, then you can go ahead and use the Versa drills for that. Are the tie bases compatible with Sirona? So the Sirona system is a little different depending on which country the Sirona system is. So, for example, if we take the American market, there is a specific library for Sirona in America. If we look at the European market, there is a slightly different library for Sirona in the European market. So our tie bases are compatible with the Sirona system. There is a workflow, and the workflow can be found on our Paltop Academy site, and you can read more about that. Certainly you can achieve excellent solutions using the Sirona system. Here I have regards from my great colleague Galit Las. Thank you, Galit. I'm missing you too. You know, this is crazy times for all of us. The coronavirus has stopped everybody dead in their tracks, and we're all getting used to a very different world right now. But I'm confident that things are going to return very soon, and we will all get together and continue with our travels and our great achievements. Is there a special library for the ACS? So on the Paltop implant site, you will find all the digital libraries, as mentioned earlier, for Exocad, dental wings, and for 3Shape. And within those libraries is also the libraries for the ACS abutment. Anybody has any difficulty finding it, once they download the library and integrate it into their system, please, you have my contact details at the end of the webinar, so please feel free to contact me and I will be happy to assist you with that. So, can you explain a bit more about the ACS? Does it have its own screw and abutments? Yes, so the ACS abutment has indeed its own prosthetic screw and a special screwdriver. It's this special screw and screwdriver combined that enables you to access the screw head, even at an angle of reaching up to 20 degrees. But the screw can be torqued down to 30 Newton centimeters, so no difficulty in tightening the screw with a torque ratchet. On the contrary, you should do that when it comes to torquing down your final prosthesis. You should always take note of the correct torque and ensure that you torque the screwdriver and the screw down at the correct torque. So thank you for that question. Thank you for your great presentations. Should you advise to use guided implant for an inexperienced dentist in implantology? Okay, that's a really cool question. I like that question. So when we think about guided surgery, I think the first thing to keep in mind is that what we have is an amazing tool for 3D digital analysis. And maybe a clinician starting out, doing his first implants, doing it in a team environment, may want to see the implant planning on its own, just in order to be able to visualize in a much more convenient way the placement of the implant and the surrounding anatomy. Tools like being able to lock onto the long axis of the implant enable you to review the implant, review the adjacent roots, review the adjacent implants. They enable you to take measurements. It will enable you to check the Hounsfield index, and not only to check the Hounsfield index, but really to get a complete color mapping of the Hounsfield index throughout the whole surface of the implant. So I would definitely say that anybody starting in implantology, if you use these tools as visual tools, they will help you understand your cases better. But no one is suggesting, of course, that guided surgery can turn any clinician overnight into an implantologist. It's important and essential that every person working with a surgical guide is qualified, experienced, has placed implants before, and fully understands the system, particularly when it comes to the Paltop system. We can, of course, and will always be happy to assist in the overall understanding of the workings of the kit and how to follow the drilling protocol with the 3Shape implant system studio. Now, we are also integrating our digital system into other libraries. We mentioned it earlier. Exciting to announce that we will also have our digital libraries in Exoplan coming very soon for all three systems, for Paltop and for Keystone Genesis and Keystone Prima. And this will offer a very simple workflow. Perhaps you're a clinician using exocad clinician chairside, and you would like to receive your plannings and design the crowns yourself. Perhaps you have a laboratory highly specialized using exocad, and they could design your temporary restorations for yourselves. So we are constantly updating the service that we are giving with Paltop. And again, to stress that we are an open system, and we do endeavor to provide solutions for everybody. So again, that appears to be the last question. I thank you all for tuning in. I wish you all good health, keep safe, keep well, and I know that we're going to see each other very soon, and we're all going to return back to some kind of normality. Thank you for listening.